Welcome to Pursuing Quality Long-Term Care, an educational podcast for individuals needing long-term care and their families. Join us as we talk with national experts and advocates about strategies you can use in the pursuit of quality long-term care. In this episode, you will hear an important conversation between 4 nursing home residents about their personal experiences with understaffing, their thoughts on the new minimum staffing standard released by the Center for Medicare and Medicaid Services, CMS, a few weeks ago, and their plans for advocating for themselves and others moving forward. The residents in this conversation are all part of Consumer Voice's Consumer Advisory Council, and we are grateful they made the time to share their thoughts with us. As background information, CMS's new minimum staffing standard requires facilities to provide 3.48 hours of care per resident per day. That translates into 3 hours and 29 minutes of care over 24 hours for each resident. This number is lower than what Consumer Voice and other consumer advocates, nursing home professionals, and nursing home residents have been advocating for years. This number is lower than what studies have shown for decades will keep nursing home residents safe, but it will still raise staffing levels at many facilities. The standard 3.48 or 3 hours and 29 minutes of care does not mean that each resident is entitled to exactly that amount of care or that they will receive this amount of care. It means that the facility must staff to the level that ensures that average. There is also a requirement in the rule for a registered nurse to be present on site for 24 hours a day. Despite providing an actual number, CMS acknowledges that all facilities must continue to provide, in quotes, sufficient staff to ensure resident safety and meet the residents' needs. You will hear discussion about the waivers that are available for specific situations that will ensure some facilities never comply with the rule, and that implementation timeframes, which means it will take years for the rule to come into effect. And with that, let's get started with the discussion.
We could start off if everyone could just introduce yourselves, share your names, your state, and how long you've been living in a nursing home. And actually, for this part, I'll just say, Marguerite, you can start.
My name is Marguerite Brochus. I live in a nursing home in Southeast Ohio, and I have been here almost 8 years.
Thank you. Maurice?
My name is Maurice Miller. I live in Maryland. I have been in a nursing home facilities for a total of 12 years. And at this particular facility for now 11 and a half years.
Thank you. Cindy?
Hi, my name is Cindy Napolitan. I live in the Dallas, Texas area, and I've lived in long-term care for 6.5 years.
Thank you. And Sharon?
Sorry. Hi, I'm Sharon Wallace. I live in rural New York State. I've been in this long care facility for the past 7 years.
Thank you. And thank all of you so much for taking the time to join us today. 2 months ago, Consumer Voice released a study where we surveyed over 120 nursing home residents about the impact understaffing has had on them. In that study, 88% of the residents surveyed said they felt their facilities were understaffed and were unable to meet the needs of people living in their nursing homes. We have a lot to talk about today, but could we just start off by taking a few minutes and talking about how understaffing has impacted all of you? And anyone can feel free to start.
I'll start by saying that I think the most significant impact of understaffing for me as a quadriplegic is that there are delays in how swiftly I get care, specifically when it comes to cleaning and feeding. I've also noticed that there are delays in the delivery of medication. And there are also days when I am not able to get up because there are not enough staff available to get me out of my wheelchair, or they have to prioritize which members of the resident community can get up and into their wheelchairs because there just are not enough staff members and not enough equipment in a shift to get everyone up at the same time.
For me, the same thing happens. Call lights are not answered. Showers aren't given because of not enough staff. But the most concerning thing that I observe is that our residents that aren't able to communicate and aren't able to feed themselves are being neglected because there's not enough people to feed them or look after them. We've had so many people fall out of their wheelchairs. A recent fall, actually, they fell twice, and they are now at home on hospice care, waiting to die due to their injuries from sustaining a fall. Those are the most concerning things to me. That people aren't able to get the help that they need, and there's not people here to supervise and to make sure that people don't leave the building. We've also had residents walk out of the building and the alarm goes off. They have a monitor on and they have been found later in the day going around the building. So there's huge safety concerns when there's not enough staff here to protect our residents.
I would like to add to that in my facility, the staffing levels are such that maybe the most basic things are being done, like feeding, cleaning, clothing, things like that. But as residents, our lives should contain much more than just that. And with more help to do activities or meet up with other people, those all require staff as well for many people.
Regarding our nursing home here, at times during our second and third shifts, we have 2 CNAs covering almost 100 residents, which means waiting 2 to 3 hours at the least to have somebody come to us to either get us in or out of bed or cleaned up, or out of our rooms to get to an activity, or even a nurse to bring us our medication. And then we're asked, how come we're not participating in an activity? And when we say we try to, we have no way of getting there. And then we're told, well, you have to find a way. And for those of us who are in a wheelchair and we need to get in the wheelchair using a machine, you need 2 people to put us in the wheelchair using the machine. And at times the machines are broken down. So there's nothing we can do because the machines are broken down, and you can't find 2 people to use it. So we're stuck on that too as well. So what do we do on that point? And we're told, well, it's up to you to work on this. That's our response. That's what we get when we question, how do we fix it?
And I would think I would like to echo the frustration that probably every resident at every facility has when it comes to the call light situation. When a facility is understaffed, you have to imagine the purpose of a call bell or a call light in part is that you are supposed to press it when you have a medical emergency. If there are not enough staff members to respond in general, what's going to happen when you press that call light in the event of a medical emergency? Most science says that you need, in case of a cardiac emergency, to have someone respond within about 6 minutes. Well, those people who have witnessed the incident with a football player who collapsed on the field realize that you need someone responding in less time than that. Otherwise, you see a person die. So if you are not able to send staff into a person's room when they signal for the fact that they have a medical crisis in an immediate fashion or as close to immediate as possible, um, you're basically gifting them a funeral. And I think that that is the most sobering problem with understaffing when it comes to um, basically responding to the most basic need a facility is supposed to address.
I think part of the problem is that when somebody pushes their call light, that the people who are responding to it have no idea what it is you're putting your light on for. So maybe you dropped something on the floor, but like Marie says, you might also have had a heart attack, and it gets exactly the same response. Too late.
Yes.
And so, and when you guys share all of this, and I know so many people listening today, like myself, have heard these stories so many times, but when, Sharon, you talk about what your experience is like, it is terrible. I mean, it is terrible what life is like for people in understaffed facilities. And I know everyone was really excited at the thought of there being a minimum staffing standard. I mean, and again, a minimum is only a minimum. It's the least required and it's something to build on. But I know everyone was excited about that. And then the standard came out, and we know that the standard means we're talking about 3 hours and 29 minutes of care per resident per day. What does that mean to all of you? And I do want to acknowledge that none of you, none of the residents participating today actually live in facilities that are currently staffing to that level. But some of your facilities are very close, within 2 to 3 minutes of this new standard already. So what does the standard mean, and how do you think it may or may not actually impact you?
Well, I'm glad to see that they did come out with a number. I've lived in my nursing home for 6.5 years. During that time, I've always heard the words adequate staffing. You cannot quantify the word adequate. It is a puffer word, a filler word. So I'm happy that now CMS has come out with a number and that we are able to find out what the staffing level is at our particular nursing home. Out of the 4 of us, my nursing home has the poorest staffing numbers. It is at 3.29, I believe, which is a lot lower than the other nursing homes on this call today.
I'm just going to interject, Cindy. 3.29, your facility, so 3 hours and 29 minutes is this new standard. Your facility is currently staffing at 2 hours and 57 minutes. So.
Oh, yes, that you're absolutely right. I was being really positive there, but no, we are not staffing at that level. So my concern is, therefore, if CMS is saying that 3.29 is adequate, then isn't my facility currently operating not adequate? So what can I do as a resident to try to get my facility to up those numbers? What can be done? I mean, because it's not operating at an adequate staffing level right now. And CMS has said that it should be adequate. And they gave us a number. So I need to figure out what I can do to encourage my nursing home to go and meet those numbers. We can't wait 2 years for this to be implemented. It needs to be implemented now. Basically, we've been operating inadequately. So what can I do to get that changed? What can we all do to get that changed?
There was a show several years ago called Are You Smarter Than the Average Fifth Grader?
Yeah.
And one of the things that show touched on was arithmetic. And if, as you said earlier, Jocelyn, when you look at this from an arithmetic basis, if you look at a standard of 3.29 hours of care per day, there are 24 hours in a day. So let's look at that standard in relation to me. All right. It takes about 10 minutes to take my vital signs in the morning. I have to be fed twice. That's about 30 minutes per feeding time.
Mm-hmm.
That's an hour right there. It takes about 20 minutes for the nurse to administer my medications. So we're talking about an hour and 20 minutes plus 10 minutes for vital signs. So that's 2 hours right there. Now it takes two people to clean me, so they have to wait as long as 30 minutes to find someone to clean me. So the cleaning time could take as long as an hour. So by the time you add everything up in the morning shift, you've consumed 9 hours. So basically, I'm done for
Mm-hmm.
the day for my care. Um, standard. So what on earth am I supposed to do based upon this standard for the rest of the day? Does the facility go out and say, we've cared for him, we've met his minimum standard of care because we've cared for him already in the morning? And what do I say that is uses words that are safe for work in response?
Mm-hmm.
Well, you can't work a standard like this out over a 24-hour period and say, okay, we've met the residents' needs. I mean, you just can't. I don't think any one of us on this call, let alone any one of us, any other residents who have high maintenance needs, can say that.
And Maurice, I am going to interject again right now because I want to make it clear to everyone listening. I know you understand this, but I want to make it clear again that what the numbers mean. An hour and 29 minutes of care is exactly as you described it. When they average that out and look at it, you've only received care for the morning. That doesn't mean you will only receive care in the morning, because again, what the numbers mean is this is how much they need to provide per resident per day overall. And so it isn't that they're literally looking at a clock for each resident. It's like, this is how much staff they need to provide. So I just wanted to make that clear. And I also just wanted to clarify, because I know we're talking about a lot of numbers here. The standard is 3.48 hours, and that translates into the 3 hours and 29 minutes, which is the number that we're all talking about here today. I know with so many numbers, it could be confusing for people listening. So
No,
I
no.
wanted to just clarify that.
Yeah, I understand what the standard is, but what I'm saying is that when you break it down, um, they're saying this is a standard per day for a resident, but a resident lives in a 24-hour day.
Mm-hmm.
So when they say per day, that's our world. Our world is not 8 hours or 7 hours, 7.5 hours. Our day is 24 hours long. So
Mhm.
that's my only point, is that however they are defining it, our day is 24 hours long. So that's my only point. I understand that the numbers are what they are, and that the intent is not to limit the numbers in a specific box. My point is only to illustrate that our day is 24 hours long, and
Mhm.
however you want to frame it, when you say X number of hours per day, you must acknowledge that our day is 24 hours.
Mhm.
And can I just put in one little thing? We're
Yes.
not only dealing with those numbers, we're also dealing with, and it's just a side note, with the staff shortage. So we're dealing with how many hours a day, and we're dealing with our days are longer because we're waiting longer period of time because there are not enough people to cover to take care of us. So when we ring our call bell, and it's on for 2, 3, 4 hours sometimes because there are not enough people to come take care of us. So that makes things even harder for us. And at times, the ones who are here, they're wiped out. They're doing double shifts more than 3 or 4 days at a time. And a lot of them are taking it out on us.
Mhm.
And we have no control over that. And, it's like we're stuck in the middle. It's like play monkey in the middle time. And it's a hardship on them, it's a hardship on us. And it's like I call us the invisible people a lot of times because that's what it feels like. We're stuck in our rooms, there's nobody coming to help us, and that we're out of sight, out of mind. And that's the hard part.
If I look at the staffing here in my facility, it may seem as if the numbers are close to what the standard is, but at the same time, I can see that there is a lot of staff turnover, where I believe something like 60% in the case of nurses. That is a lot of change and a lot of people that don't work with you on a regular basis, that don't know you. It means to me that you have to explain time and again how you wish to be treated, and all that is part of understaffing.
Yes. Yes, I agree with that, Marguerite. I feel like I am their trainer. Every time a new person comes and starts to work with us, we have to train them um, and tell them how to do every little thing. And once we get a CNA that is here consistently, they can work with us much faster and get their job done quicker and more efficiently when they work with the same residents every day. But that doesn't always happen.
Of course, when you work with the same staff that you are used to, life becomes a lot easier because you do not have to explain. You build trust. You know more about them, they know more about you, which makes for human interaction, which is extremely important. It's not just plug in the numbers and this is how many people you need to take care of those in a nursing home. We are human beings, and we would like to interact on a human level.
Yes.
And one of the things I've also observed, having had several different roommates that I have not known, is that um, we become part of the staff. So we often are the ones educating the staff on how to take care of the staff because we are the ones who live with our new roommates and interact with them more frequently than they do. Um, they quite often are asking us or are in need of us explaining to them um, how to communicate with those staff, with those new roommates, or perhaps how to interact best with those new roommates, especially if those new roommates are not accustomed to the new surroundings or perhaps are difficult to deal with in some cases because they are scared or are frightened or are not completely aware of their surroundings. So in those situations, um, a low staffing standard means that we are the ones that are making up the difference and also dealing with a low staffing standard ourselves. So we're doing dual duty. And, that's, kind of unfair all the way around.
So, the next question I want to ask, and just briefly, but Marguerite, when you started talking, I was thinking about it because you live in a rural facility. The new staffing rule has waivers in it. The waivers can be a little bit complicated, so I am not sure if your facility will qualify for waivers or not. But some facilities will, and that means some facilities are not going to have to comply with this standard that's designated to keep residents safe. And then there's also an implementation time frame. So in the best case scenario, there's a 2-year wait before we even see this implemented. I just would like to hear your perspectives on that.
Okay. I am in a rural facility, and according to the new rules, the requirement of 24/7 RNs in the building they will have 3 years to implement that, and the real standards up to 5 years. And I'm quite sure that a good number of the people who are in my facility right now will not even live to see that happen. That's sad.
Mm-hmm. Yes, that's definitely sad. That I tried to calculate how many RNs would have to be in our building right now we have 110 residents. We sort of figured out that we would have to have 4 RNs in the building. Right now, I believe our DON is the only RN that we have, and she only works Monday through Friday. I'm not even sure if we have an RN on the weekends. I've been told by many nurses that RNs prefer to work in a hospital setting over working in a nursing home. That's just what I've been told. I don't know how RN staffing is in the rest of your facilities, but here it is very poor. So I am concerned that requirement is going to be hard to fill. And that might be a waiver that they may give, just the option that we aren't able to hire RNs. I don't know if that's a possibility, but that concerns me.
I talked to our DON yesterday about the requirement for having an RN 24/7, and she said that will be so hard for us to do. It's true we are a small rural facility, but we are also part of a 58 nursing home conglomerate. So we're not small in that sense. And I'm sure that they might not like it, but at some point they will have to start thinking in that direction. And I hope that this 5-year stretch and 3-year stretch that are set out for rural facilities, that it doesn't mean, oh, 1 month before the time is due, we're going to start working on that. I hope there would be something that says you have to start working towards it now, and you'll be set by the moment it is actually compulsory.
We live directly across the river from a major metropolitan city. But with the exception of one agency RN who works on occasion, the only RNs that we have here are on the management team. All the other nurses here are LPNs, and that has been the case since I have been here. Those individuals who have wanted to become RNs through their studies have worked to do so, and then worked to leave once they get their RN degree or their BSN. Um, I think Cindy is right. Um, the goal of becoming an RN and staying within the nursing home environment um, are oxymorons. And I don't know how to fix that.
And that's because our nurse, our LVN, takes care of 38 patients.
That's part of the problem. Yeah.
That's a really big problem. That is just too many people to try to take care of. And if you have an RN that can go to a hospital, and we've got several CNAs that work at some of our hospital facilities, and they take care of 4 patients, is all of our CNAs take care of. And they do mostly vitals and do some other nursing activities, and not so much of the cleaning and changing, because they're mostly critical care. But if a nurse can go and just take care, an RN can just go and take care of 4 patients versus working here and taking care of 38, I mean, that's a no-brainer. I think most people would want to go and just take care of 4 people at a time. That's a huge responsibility to take care of 38 residents. And they all could crash at the same time, right?
Yeah. I had an issue a few months ago where I was having heart problems, and it was during the 3rd shift. And my regular LPN was trying to get me to go to the ER.
Mm-hmm.
Supervisor kept saying, no, 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 no. She kept forcing me to take nitro. I never had nitroglycerin before.
Mm-hmm.
They made me take it 3 times. Then they called another supervisor who kept saying she was an RN. The 3rd person that they called down was not an RN. She was a physical therapist. I know this because I did physical therapy from her. And I'm looking at her going, you're not even a nurse.
Oh, wow.
How can you pick yourself up as a nurse?
Oh my gosh.
And they're looking at me going, oh, you're not feeling well, so you don't know who you're talking to.
Hmm.
And I'm looking at this going, all right, I know I'm not feeling well, but I know the difference between a nurse. I know the difference between an RN, an LPN, and a physical therapist. I know during our 3rd shifts lately, we have 1 nurse covering over 130 patients.
Wow.
one, possibly two CNAs covering the same amount of people.
Oh my
I
gosh.
bring this up in our resident council meeting, and the administrator we have saying, there's no problem. Maybe we have a person who calls in. I went, maybe? There's no maybe. You've got to have somebody covering for this. This is how do you handle your people, your staff, trying to take care of us with this type of, I don't understand. Explain to us, how are we supposed to be taken care of this way?
And let's not forget,
Look,
yeah, let's not forget that the biggest hurdle um to the RN staffing standard is probably one that the nursing institutions wants us to ignore, and that is the profit problem. It is less costly for them to employ a group of LPNs than it is for them to employ RNs. And so the reason that they're going to ask for waivers, dollars to donuts, is going to be because, not because they can't hire RNs or that they cannot find RNs, is because they have to pay RNs more. That's why there are less RNs right now in the facilities, in addition to the reasons we've already cited, is because you can't pay an RN the same that you pay an LPN. When a person gets an RN, they immediately command more money. And so when you have a staffing standard that says you need to have more RNs, the reason there are going to be more requests for waivers is because it's going to cost those institutions more money.
Thank you for making that point, Maurice. And so can we talk about where we go from here? The standard's out. It hasn't been implemented yet. You're a group of resident advocates. Sharon, you mentioned working with your resident council. Many of you have or currently are resident council presidents. You advocate for yourselves and for others in your facilities on a lot of different issues, on a lot of different levels, and many of you have advocated on the federal level. But I want to talk a little bit about that work within your own facilities. Can we talk about what residents and families can do or should do, or what you think they should do at that very local level right now in their own facilities about understaffing? Because I mean, I'm listening to you. I'll talk about what a big problem it is for you. And I know you all have the tools and the education and the experience in being leaders. And there are a lot of residents new to facilities and people who are just sort of experiencing this and they don't know what steps to take and what to do. So,
well, my first thing that I'm going to do is I'd like to share that I am starting a family council here at my nursing home. Since my daughter lives here, I am a family member. So I have started that. Jocelyn, I have not had any luck talking to my ombudsman and getting any help from her. I tried to call Susanna. They didn't give me Susanna. They told me to wait until my ombudsman contacts me. So I'm having some difficulty there. But my plan is now that we know how to get the information on staffing numbers in nursing homes. My idea is to look up all the nursing homes in my area and compare our numbers to the other nursing homes in the area and to share them with everybody that I know, all of the family council, the residents, and this can be something that we can present to our administrator and say, what's up with this? We have the lowest staffing hours here. I mean, you should be embarrassed by this number, and you should be wanting to increase the number and improve the conditions here at this particular nursing home. I mean, it's all about communicating, and that's my plan, is to get the family council involved and show them on paper what's happening in this area, and also to make them known that all of the family council members know about these new CMS rules that will be coming out, and make everybody fully aware of what's going on. That's my plan. So hopefully it'll do something. I don't know. We have to try something. We have to get the word out.
And I think I want to approach it similarly to what Cindy does but I want to start from a coping mechanism standpoint. I believe that there are a lot I've seen over the time that I've been here, a lot of angry family members who have taken their um residents out of here because of frustration with the care they've received. I've seen a lot of people um grieving because of a resident has passed. I've seen a lot of frustration among the resident family community over things that have happened. And I think that there is a lot of grief, there's a lot of anger, and there's a lot of despair. And I think that there is a way of channeling all of that into saying we need to support one another, pray for one another, and find ways now that we know that we all are in this together and say, well, what can we do about it? What can we do to alleviate that grief? What can we do to reduce the number of people that die here needlessly? And then we can say, well, these are the numbers that have come out, and these are the things we can do to challenge those numbers to make sure that we have better staffing. This is what we can do to make sure that the agency people that we have here are more clued in. This is what we can do to make sure that when things don't go right, these are the things we can do to write up complaints and to write up and demand more surveys. But we start off by coming together emotionally and supporting one another, I believe, and saying that we are a family and that we need to support one another and pray for one another and love one another. And then say, what do we do now that we know that we have a common problem? Is as basic as a civil rights. We find out that we are all disenfranchised, and then we go from there and we find out ways to reclaim our own dignity. So that's my game plan.
Excellent.
I think for me, a good place to start would be the resident council, and to have more people there who realize that whatever they say there stays there, and that this is a sacred space for residents to come together and talk about things that they see that are not right, and have it taken to the rightful places to get addressed. Is this easy? No, because many times people feel that they cannot express what they see, and I think fear of retaliation is real. So, but getting more people on board to talk about these things, I think, is very important, because there is strength in numbers.
Yes.
I think with me, I got to get myself back out there and start introducing myself again to people and get more people into the resident council and letting them know we're here to help them and saying, don't be afraid to speak up in this room. We're not here to make waves. We're trying to get things better. And, just there's certain people who know they can come to me and know I'm not going to be a blabbermouth, but then they know I'm also not afraid to talk to the administrator. So that's what I'm going to keep continuing to do.
And make one mistake, Jocelyn, I think that we are all going to have to communicate based on our own experiences that this journey is a very hard one and that it is not something where you would expect accomplishments by leaps and bounds. It is Advocacy is hard and it takes incremental steps, but you have to start somewhere. And the more people that you have involved in the start, the easier it is to get somewhere and the faster or it seems that you are accomplishing your goals, but you have to start. And and if you do not do anything, nothing will change. But I think all of us can attest to the fact that it is hard work and but it is worth it as long as you don't stay still. And that's the message that we're going to all have to communicate to everyone we talk to is that you cannot stay still. And that for far too long, that has been the problem among us. And that if we do join together, the more we move together, the more we move step by step, the closer we will get to some sort of victory.
Yes.
Well, I think, Maurice, that's an excellent place to close out. I want to thank all of you so much for joining us today. And for being so proactive. I mean, I think when I asked that last question, it almost sounded like every single one of you had a game plan written down to respond to it, which I think is for people listening really inspiring, because we started this conversation off with you talking about really the indignities that you deal with and that you see other people that surround you dealing with on a daily basis. And despite that, we ended with you talking about, Maurice, as you said, coming together and trying to get that incremental change. And I think that's what we are all doing in this field. But it is particularly inspiring when we hear you talk about it. So thank you so much for being here today with us.
I think advocacy is not a sprint. It's a marathon, and you have to keep it.
Absolutely.
Yes, definitely.
Thanks for joining us on Pursuing Quality Long-Term Care. This podcast is a program of the National Consumer Voice for Quality Long-Term Care. Make sure to visit our website, theconsumervoice.org/pursuingquality, where you can subscribe to the podcast, follow us on Facebook and Twitter, and find more information and resources. If you enjoy the podcast, please rate, review, and subscribe. Thank you for listening, and we'll see you next episode.